Peter? We already know you. Don't.
All right. Thank you very much. I think this is the talk that I gave this morning. So it's the other talk. It's cardiovascular risk. Can we go forward? Whoops, go back. Can we? All right, this is the right one. All right, so it's about cardiovascular risk in men. So prevention, prediction, and precision medicine. I will editorialize as I go along from what I've also heard today. I'll mention when we get to the cardiovascular risk in men, I'm going to say how I interpret some of the results as well, because we just heard about the TRAVERSE trial, which is a very important trial. It came out in the last couple of years. And I'll give you my interpretation as an endocrinologist. We've already heard a urologist opinion, but this is a trial that's probably one of the most important for all of testosterone replacement therapy. So, okay. Now, this is going to be a little bit easy. This is after lunch, and you may fall asleep, and I'll maybe stomp my feet every minute or two, so to remind you that if you ate too much lunch, you're probably going to fall asleep. You know, that's what happens if you eat in the middle of the day. And but this is where we are. We now have new risk algorithms every 3 to 5 years in the United States. Europe is similar. And what do you do in Latin America? What do you do in Central America and in South America? You generally do what we do. And in fact, I'll be honest, in the future, you probably are going to, as you create more and more medical records that have electronic systems, you're going to create your own. You're not going to just follow what's happening in Western Europe and in North America. You're going to create your own, and it's going to be slightly different. I'll give you a hint. I think it's going to be a little bit more like other parts of the world where they're also developing new algorithms. So this is already happening in India, to give an example. It's being put together by investigators from Emory and from major cities across India. It'll be published in the next 6 months, and that'll give you a flavor. It's much more oriented towards the metabolic syndrome as the precursor for who gets heart disease. But this is where we've been. And I say a little bit why you go all the way back to 2001, because the algorithm that was used in 2001, I created. It was based on Framingham. And 2013 was sort of Framingham extended to other populations. And then 2018 was yet a mild version of some changes. And then 2024 is a new change, a major change. And I'll review most of what's happened there. And then I'm going to give you the new science that's related to all of this at the end, okay? So these are the variables. And everybody should, by the time they're 50 years old, you should know these variables. As a man and as a woman, women generally don't get heart disease before menopause. The women who get heart disease before menopause are especially diabetic women and women who smoke. And if you do both, if you're a diabetic and you smoke, or if you're a woman, you are especially at risk. Easy things to remember. Historically, and this is for the younger people in the room, historically, we used to say every risk factor doubles risk. 2 times 2 times 2. 8 times the risk if you have 3 risk factors. Everybody can remember that, to say that to a patient. You can say that to your colleague as well if you have 3 risk factors. 8 times the risk of somebody else your age who doesn't have the risk factors. But we've changed the risk factor levels. Risk factors used to be way up here. For hypertension by World Health Organization, when I started my training, was 160 over 95. Now our targets are things like 130 over 80 or less. 120 over 80 becomes optimal. So risk factors are now 1.5 times. So it's 1.5 times 1.5 times 1.5 if you have 3 risk factors. That's another simple thing for you to remember, and for yourself and for your patients. So most of these risk factors are just like that, okay? I'm going to give you mostly factoids. Factoids, I learned this new word today, you know, that's why you come to conferences and you hear things like these new terms. But factoids, why do you take statins? More people are taking statins. They were first created in 1987. They first got rolled out. Didn't even have a name for this class of drugs. The first drug was lovastatin. Now we've got about 7 or 8 of them. And why do you patients take statins? Because of this slide. This is the world's literature up until around 2011, and it hasn't changed much. And it's the bottom line, 22%, 0.78 hazard ratio, 22% risk is reduced. And about half of that is for mortality. So why does my patient take it? He's got to have a 10% reduction in whether he's going to live or die, and he's going to have a 20% reduction in heart disease risk overall. Now that's for total CHD or hard CHD, which are in the middle of this. Why is he showing this slide? Because nobody has done this as well as it should be. You should have all of these types of outcomes. So the new American guideline does not have that number at the top, that blue bar going across. Yes, it does not have revascularization. So Deepak Bhatt, and many of you have met Deepak or heard him speak at international conferences, more than half of the events in the United States are now becoming revascularization. And that was true in most Paul Ritker's recent pemafibrate trial also. Half of the events are revascularization. So the older rules are not perfect. They give you a guidance, but they are just, it's like a compass. You're out in the woods and you want to know which way is north, which way is south, but they're not perfect. You can still fall into the ravine. You could still get in trouble. And some of these other events, cardiac failure, that is now included with the most recent one. But in general, it's a separate prediction for a heart failure, and that you need to be very aware of that. And the most modern way to get heart failure, I can remember when I was in medical school, you got a heart failure by having a heart attack and then your heart failed. As my mother said, there's 2 ways into a house. There's the front door and there's the kitchen door. My mother was a housewife. She would say the side door nowadays, but she said the kitchen door. And you get into other types of heart failure by going through the kitchen door. You don't go through the front door and have a heart attack. You get you have reduced ejection fraction. Heart failure is the classic. You had a heart attack, you have heart muscle death, and you get it that way. But if you go through the other one, you have preserved ejection fraction. And that is becoming it rivals. About 40% are HFpEF, 40% are HFrEF, and 20% are sort of in between. So you got to pay attention to both of those. So I like these types of diagrams because whenever you say I'm going to predict something, you could also predict another event. For instance, if you get the classic, which is what most of these algorithms have been developed upon, you would get MI, stroke, or cardiovascular death. But then you could get heart failure. Or vice versa, as I was just saying, you get the modern version of heart failure, which we didn't really recognize 50 years ago. You're at tremendous risk to get any of the events at the top of that slide. And then cardiovascular death or heart disease death is the final common pathway for many of these patients. All right, I'm going to quickly go through some of these. This is from Sadia Khan, who's at Northwestern, who's been leading the charge for many of the newer algorithms. And what happens when they develop algorithms, you have a derivation sample. It's usually half of the data or so, and then a validation. So you test it. And look at this at the number at the top. You've got millions of people. Average ages in the 50s, plus or minus 13. So they're getting people basically 30 to 70 years old. It gets a little weak once you get below 30 and very weak once you get above 70 or 80. It has different representations across races and groups, and it adds new factors. Those are the new factors. And I'll just mention each one for very quickly. What do you think statin treatment does? Yeah, it's about a 10% to 15% reduction in risk. So if that's added in, if you're already on a statin, yes, it does. Okay. Hemoglobin A1C, what do you think that does? Higher hemoglobin A1C means worse diabetes control for glucose. It's about a 0.5% to 1% for each unit. So if you see your patient with a A1C of 10, and I've got lots of those patients, mind you. In my clinic, I have lots of them in the VA, versus the target is 7, he's going to be, 90%, 90%, 90%. He's going to be a higher risk. Actually, it's 1.1 times 1.1 times 1.1. He's going to have a 30% higher risk than the next patient with exactly the same things who has an A1C right at target. And these are important for all patients, okay? eGFR. If you've got, first of all, even if your creatinine stays the same and you get older, your eGFR goes down. That's really unfortunate, and I'm looking at these right now myself when I get my reports. That is a determinant as well. Obesity is generally not a determinant because it works through the metabolic syndrome. Then he puts in zip code. Why did Americans put in zip code? Well, we didn't want to ask in the modern era about race and ethnicity, et cetera, et cetera. It's a helpful thing, but in general, once you have all these other factors, it's not very strong an important factor. And then there are other modulators, depending upon what you have. I'm going to skip by this, but the point is there are different, I'm just going to emphasize a couple things. These are the hazard ratios. So like at the very top, blood pressure medication actually is increased risk, not a decreased risk, because we probably start treating patients late. And as I showed you right there, remember I just said hemoglobin A1C in diabetics is 1.14. That means it's 1.1. It's about a 14% increase in risk for each unit. So if you're, as I said, a patient of 10, that's, you really want to be at goal if you can, okay? Now, this is an example. You can get these types of calculations. You can do this here in Panama. You can do it throughout the Americas. You can get preventive risk, lifetime risk and 10-year risks for both heart disease and for heart failure, okay? Now, all right, so what is the advantage? Well, we have more contemporary experience. We have statin data in there. We have kidney function. We have hemoglobin A1C. They work pretty well in the United States. It's a lot of a black box, we call it in the United States. Michael Pensina, who's at Duke, who did this, constructed these equations. He's one of the most brilliant population prediction scientists in the world. It's not simple to replicate this somewhere else. And it has these newer factors that everybody wants to have, okay? What are the limitations? And this is being tested left and right, including in the VA. We have a paper that's addressing this. But already the Harvard and Penn groups have shown that the PREVENT underestimates risk, and pooled cohort in 2018 overestimates risk. So what am I supposed to do? I probably should do both. So I have two estimates. And we're testing that, as you might guess, in the VA. We're going to probably come up with our own because we have a very large database. Okay. So can you use this in Central America and South America? I would suggest you do both. You do sort of what's been recommended, even in the PREVENT paper itself, do both PREVENT and the pooled cohort from 2018. And then look what's missing. It's the wish list of a lot of scientists, including me and others. Paul Ridker, who's been an advocate for C-reactive protein, says, where is CRP? Brain natriuretic protein, which is for heart failure risk, even with the person pre-heart failure, is not there. Some patients leak troponin because they have minor cardiovascular myocardial damage, not there. Lipoprotein A, that's going to be the molecule of next year. That is going to hit the big time next year as a cardiovascular risk factor. We already know it, but it's not been incorporated into any of these risk calculations. And then finally, coronary calcification, which was shown in the MESA study as it reassesses risk. And I'm going to show that as we finish up here, reassessment of risks. And it did not, as I said earlier, it does not include coronary revascularization, which in the States is about half of the events, okay? Certainly a third. It also, you can get a lifetime risk. I encourage you to calculate your own lifetime risk. It'll be sobering. You're not going to live forever. I think all of us over 60 know that. We'd like to wish it, but you got to, this has been, the whole field been pioneered by Don Lloyd-Jones, who has got behind this for the last 20 years. Now, couple things. Artificial intelligence. As I mentioned earlier this morning, artificial intelligence is how to use data in modern ways and novel ways. And this is something that Michael Pensina and I developed. And this is building on Jared Diamond's use originally for cardiovascular treadmill scoring. So you have a test positive. Everybody likes to think if I do a test twice, I can do it. But you may actually go test positive, you have test negatives if you repeat the test. But in fact, you have an initial probability, and now I'm going to take all those and make them into individual points. So as you test, some people go up, but then others go down. This is on an individual basis. And you get what is called reclassification probabilities. And every new factor is being tested with this type of construct. We don't just always add in another factor. We assess whether they work, and this is using Bayesian analysis. And you've got to have a statistician, you've got to have a lot of big data sets. So this is an article, the results from what we found in the VA. So this is a traditional risk factor, and then polygenic. So traditional's on the right of this slide. And as you go along and you follow up to 6 years, as you can see there, I do not want to be in that red line. That's 81 to 100% risk. And as I get up there, my risk is 12% for the veterans, okay? So you see that? So it's a very steep line. Now, polygenic risk score, we did this in, this was a data based on 600,000 veterans with a 750,000 Affymetrix GWAS chip. Well, it's a lot less steep. You know, it just sort of gradually rises, as you can see there. So am I going to beat out if I know my genes, or do I want to know my traditional risk factors? Well, you would say, I really want to know both. Yeah, but let's say you just start out with a simple question. Which one? I want to know my traditional risk factors, because that is really, and that's been tested time and time again. But we did this, and so, all right, so I asked the question, what, you want to know both? Well, here, this is how you do it with both. And we've done this, the UK Biobank has done this, and yes, it does count. So where did it count, okay? So it counts for the women in one group, and that's the younger women, okay, versus, and that's with the different colors, and the key is going to be on the next slide. And then for the people over 55, didn't matter so much, but it had a greater impact in some of the groups, but not statistically significant for those under. And then the same sort of thing here is reclassification. Again, it worked for the younger people, especially in the blue, and especially, look at that. Look at that. What group did it really work in? Hispanic veterans in the United States. There's this so-called the Hispanic paradox. Does everybody know? You should know that. Here we are in Panama, is they can have the risk factors, but they don't get the heart disease. Certainly not quite the way the white population in the United States. So the Hispanic paradox has been pretty well investigated in the U.S., but you need to do more of that here, Central America and South America. So in summary, CVD prediction continues to evolve. We're now starting to use more and more data. We're testing things with newest techniques to assess whether a new factor actually makes a difference. We have lower targets, so risk factors are no longer quite the same. They used to be doubling, now they're 1.5. We're now moving more and more into subclinical disease, as we were hearing about, with echo data, et cetera. We have newer biomarkers, we have genetics, and the next generation is actually going to be the environment itself. And I'm collaborating with people to do that as well. Thanks very much. All right.